continue from the part which we had left over last session. We have discussed about the conditions like vasculitis, where there could be obstruction to the vessels. Now, in brief, there are many other conditions which we call as a hypercoagulative conditions. That's the conditions where there could be a situation where the blood may get clotted and the blood vessels may get blocked. The same consequences as we have discussed earlier would occur. Now, among them, as per the literature, prior to 1993, only 3 inherited hypercoagulable conditions were recognized as antithrombin 3, protein C and protein S. But now, as per the present situation, there are mainly 5 categories which are genetic, which are produced due to either genetic or related to the physiology of the body, and they are either coagulation factor inhibitors abnormality or increased level of the coagulation factors and homocystinemia, defects of fibrinolytic system or altered platelet functions, etc. Now, in all these conditions, the clinical presentation would be the same as we have discussed. As such, there could be peripheral ischemic signs, and the treatment protocol also is the same. The only difference is because it is a genetic pathology, it cannot be reversed. The other issues are the same, so we will not repeat the same. There could be even acquired causes of the hypercoagulability, and those are mainly the oral contraceptives or estrogen replacement therapy. Patients who are on oral contraceptives or estrogen regularly, they are more prone to develop the coagulation disorders. Pregnancy is also another of the condition. Then venous thrombosis is related to venous thrombosis. We will be discussing separately later on in the coming sessions. There are deep vein thrombosis, which could be related to the traveling or inactivity. Then malignancy or severe illness like nocturnal hemoglobin nephritic syndromes or inflammatory bowel diseases also can present with the hypercoagulability, where the same situation like peripheral ischemic symptoms could occur. So that's in brief about the ischemic conditions. The next part which we discuss is about the venous abnormalities. Among them, the varicose veins, or which also the other way, the venous insufficiency syndrome. Spider veins is a term used for the small finer vessels which are seen, and when you say varicose veins, the dilated vein are the varicose veins. This nomenclature, of course, is not much of a big issue. Maybe the spider veins suggest about a relatively minor pathology, whereas varicosity comparatively bigger veins or bigger veins dilated as such. Its definition of this would be when the blood is deviating from a normal flow path and flows in a retrograde direction in the veins. In the normal direction of the flow in the veins is towards the heart, and if it becomes a retrograde, it flows to the other side, then it is called as the venous insufficiency syndrome. Now, in the lower limb particularly, the incidence is more common, so we will be focusing more on the lower limb pathology. The lower limb, the venous drainage system has 2 components. One, the deep vein component and the superficial vein component. The deep vein is surrounded with the muscles, and that is a major vessel which carries the blood to the inferior vena cava, and at there are main the saphenofemoral wall which keeps that blood flow unidirectional. And the deep vein, in the deep veins, the circulation is facilitated by the muscular pump, the contraction of the muscles of the leg. Whereas the superficial venous system is where you will have the saphenous vein and its branches over the surface, which drains blood from the surface of the leg as such, and this blood will be flowing from the superficial venous system to the deeper venous system through the interconnecting veins, which are also called as the perforating veins. The number of such perforating connections are something like around 4 below the knee and 2 above the knee, and then of course the major one is the saphenofemoral wall. At the saphenofemoral wall, the saphenous vein, the greater saphenous vein, merges with the deeper vein, the femoral vein, and there the blood will be made unidirectional. And the other perforating veins, of course, are named as the Hunterian on the proximal thigh, and broad perforating vein the distal part of the thigh. Then below the knee they are the Boyd's and Crockett's perforators. Of course, the number of these perforating veins may be varying, though it's 4 to 6 would be there. Number of such veins are there, and these veins, perforating veins, keep the direction of the blood flow from the superficial venous system to the deeper venous system. Now, an abnormality, a retrograde flow can occur either when the deep vein is blocked. If the deep vein is blocked, then all the amount of the blood has to go through the saphenous system, the superficial venous system, then it gets dilated. That's one sort of the pathology, a condition where there is a blockade. Or the other way, it could be due to a abnormality of the perforating veins, the perforating valves there. The valves which keep the blood flow unidirectional from the superficial venous system to the deeper venous system, if they get somewhat defected, like, then there could be a reverse blood flow from the deep vein into the superficial venous system, and that can produce varicosities. Or the third possibility is if there is an increased intra-abdominal pressure, the pressure in the abdomen is increased, that results in the incompetence of the saphenofemoral valve, because the pressure from the other side is more, the saphenofemoral valve gets weakened, like, or is not capable of sustaining that force. Then the blood will flow from the inferior vena cava into the superficial venous system. That's how the varicosities can occur. So varicosities can occur due to primarily 3 categories. One, where the deep vein is blocked. Now that category we will be discussing separately. Deep vein thrombosis we discuss separately. The other 2 categories are where there could be abnormality of these perforating veins, structural defects of the perforating veins, and hence the varicosities could occur. Or there could be a situation where the intra-abdominal pressure is increased, and hence the saphenofemoral valve becomes incompetent, and that results in a varicosities. So varicosities could be of different categories. Now a healthy vein valve keeps the blood flow unidirectional, whereas in the conditions where the vein valve has become diseased due to either congenital or acquired causes, the blood flow can be in both the direction, and it will flow from the deeper venous system to the superficial venous system, and that results in the reverse flow. And the venous insufficiency or varicosities, they are categorized under 3 categories: primary, secondary, and congenital. Congenital are where there is a defect in the perforating veins due to the other causes, like where the valves are defective and so on. Then the primary is where there is an abnormality of the valves which are acquired, like either fibrosis or maybe an injury to the valves, which can result in that. Secondary is when it is produced due to the reasons other than that, like pregnancy, obesity, ascites like conditions, where there could be intra-abdominal pressure is increased, and that results in the varicosities as such. Or the deep vein thrombosis, as I told earlier, the deep vein thrombosis where the deeper veins are blocked, and hence there is an excess of blood flow which can produce through. Now once there is a chronic venous insufficiency due to any of the conditions, the clinical presentations could be of 3 categories. Initially there could be either minor symptoms like pain or calf muscle, these cramps in the calf muscles could occur, or mild edema, or which may not be showing the dilated veins as such. Or the next would be there could be dilated veins, which again are now usually named as varicose veins or reticular veins or telangiectasia, depending upon the size or prominence. I will show you the picture like this. Simply the issue of nomenclature, not much of an issue. Then there is a possibility of post-thrombotic syndrome, which can present with the complications like ulcers or degeneration of the adipose tissue and the skin, and or the edema as such. Now what I mean by spider veins and the varicose veins or spider veins are fine dilated vessels which are smaller, varicose veins are bulged as such. So this is a issue of only nomenclature. The clinical symptoms of these would be when there is a spider veins initially, that finer veins. The clinical symptoms could be local burning or simply throbbing like feeling, cramps or like fatigue could be the symptoms. When the varicose veins do occur, chronic varicose veins do occur, the symptoms may present as heaviness in the leg or exercise intolerance, pain or tenderness along the course of the vein, pruritus or itching at the area, burning sensation, restless legs, night cramps, edema, skin changes, paresthesias or altered sensations also could occur as the clinical symptoms of the venous insufficiency as such. Now, to confirm the varicose veins from the clinical point of view, of course, there is no need of any other specific investigation to identify the varicosities. The only issue is to identify which of the perforating vein is defective or whether the varicosity is produced due to deep vein thrombosis or not. From the clinical management point of view, the important issue is whether the deep veins are patent or not. If the deep veins are not patent, then as the venous drainage is totally dependent on the superficial system which are dilated, it's better to not to intervene. The interventional procedure should be avoided. If the deep veins are patent, then we can think of intervening procedure, and hence the clinical diagnosis of a varicosity is very simple because it is obviously visible. But the clinical tests and investigations are necessary to rule out the possibility of a blocked deep vein and or to locate the perforating veins. Now, the two standard tests which are used in the clinical practice are the Brody-Tendlenberg test and the Perthes test, which are to identify these abnormalities. The Brody-Tendlenberg test is done by keeping the leg elevated initially and then squeezing the varicose veins superficially. Then once you have done that, the varicose veins are squeezed out, then you tie a tourniquet, and with the tourniquet on, the patient is made to stand erect. Now, if the perforating veins are defective, then at that level where the perforating vein is defective, there could be bulging. If it is a saphenofemoral valve abnormality, as long as the tourniquet is on, there will be no dilatation of the veins. Now, once you have released the tourniquet, the saphenofemoral valve gets opened, and hence the bleeding could occur, bulging could occur. Suppose if there is a vein or perforating vein dilated somewhere, then or the dilatation starts at the thigh, suppose, then you may repeat the test by tying the tourniquet at a lower level and then identify which of the perforating vein is defective. So Trendelenburg test or Brody-Trendelenburg test is done to identify which of the perforating vein is defective, and it's true only in those conditions where the perforating veins are defective, or identify saphenofemoral valve incompetence. You may have a situation where all the perforating veins may be defective. In such conditions, once the patient is made to stand erect, you will have the vessels dilated, and when you repeat the tourniquet test by tying the tourniquet to different levels, there too the same situation would occur. If it is any single isolated perforating vein which is defective, then by tying the tourniquet to different levels, you can pinpoint which of the perforating vein is defective. Then the other is the Perthes test. Perthes test is to rule out whether the deep veins are patent or not. The technique of this would be when you have the varicose veins and you tie a tourniquet so that the drainage from the superficial inner system has become reduced, then ask the patient to walk. When the patient walks, if the deep veins are patent, then as the blood flow in the deeper veins are better, or during the contraction of the muscle pump activates the blood flow in the deeper veins, the bulging of the varicose veins become lesser. As the deeper muscles are contracted, the bulging of the varicose veins will become lesser, or they will not be visible. Bulging will become less visible. When the tourniquet is on, and as the patient is made to walk, during walking, the varicose vessels will be constricted, or their bulging will be lesser if the deep veins are patent. If the deep veins are not patent, then as the patient walks, still the bulging increases. Rather, bulging may increase as the patient walks, because the contraction of the skeletal muscle doesn't improve the circulation. The contraction of the skeletal muscle can improve the circulation only when the deep veins are patent. So these are the two important clinical tests by which you can make out whether deep veins are patent or not. The other common test would be the Doppler study. Doppler study can help you to make out exactly or accurately whether deep veins are patent or not, as well as it also can help you to identify which of the perforating veins are defective. Now, from the clinical point of view, there is a method of grading these venous disorders, and the grading would be again from C1 to C6. And the C1 is where there is a simple telangiectasia, like minor vessels which are dilated, but there is otherwise venous incompetency sign is not seen. When there is a varicose vein without much of an edema, that's C2. The varicose veins with gross edema is venous edema, and when that edema results in stagnation of the blood in the subcutaneous tissue, and then there is a pigmentation and skin changes occur, then that is a C4 level, and C5 and C6 are where there are varicose ulcers or venous ulcers, different depending upon the number. If it is only a single ulcer, it's a C5. More than one ulcer, then it's a C6, and this is the standard method of classifying these as such. Now, one of the major complications in due course of time of the varicose veins would be lipodermatosclerosis. Lipodermatosclerosis, where there is a sclerosis or fibrosis of the fat tissue as well as the skin, and hence the appearance would be that the skin becomes somewhat eczematous, thickened, and there could be mild exfoliation. As the fat tissue is dissolved or has become constricted, the shape of the leg at that area becomes again narrower, and this sign is very characteristic as such. Or it may result in a venous ulcer. Of course, we will discuss venous ulcer separately. Characteristically, a venous ulcer would be having a whitish small area around the ring or ring-like appearance around the ulcer due to the dead skin area. Then the surface of the ulcer would be thin and less granular, absence of granulation, and there could be a watery fluid or serous fluid which comes through. The skin around the area would be having signs of inflammation or blackish discoloration due to the stagnation of the blood, and this kind of a superficial ulcer which usually occurs on the shin of the leg, it's the characteristic of the venous ulcer. A venous ulcer also can present with the very deep complications or secondary complications and gross necrotic changes, or there could be only the skin changes like eczema, skin changes of eczema also could occur, or there could be even contractures in due course of time. The tendons may become constricted and equinovarus deformity could occur. Now, characteristic features of these varicosities are the symptoms like vague symptoms like cramps and the pain may occur usually in the advanced ages, old ages. Younger age, the symptoms may not be very conspicuous or mild, and as the condition progresses and the age increases, then it may just go on increasing. Another characteristic feature is that the pain will be more in the initial stages. That's one important issue. Initial stages, as the stasis starts, varicosities, initially the pain symptom would be more, but later on, once the veins are become prominent, then the intensity of the pain would be lesser. Then in the advanced stages, like later on, when there are certain more complications or more stagnation, then again the pain may become worse. So in the middle phase, which is quite a long duration, patient may not have much of a symptom, and most of the patients who come to you would be at that phase where there would be not much of a pain and no other much symptoms except maybe the visible veins as such. Whereas in the initial stages there would be more severe pain. Later on there could be again the complications which can produce the pain and other conditions. And the symptoms do not relate to the size of the varicosities. Many times there is gross varicosities may not produce any gross symptoms, mild symptoms as such, whereas a smaller thin vein can produce more severe symptoms. So that's depending upon how much of the blood is reflux like and not the size. And majority of the patients again, because the condition is a very gradual process, they may not really know that they have a complication. or they have the symptom, because they become accustomed to that kind of symptom, and hence they will feel that it is asymptomatic. But once you have done the treatment, and then after the treatment, once the patient is relieved of the symptoms, they may say that earlier we had that kind of a symptom as such. So many times it happens like this, like the patient has come for some other pathology, and you give some prescriptions like Kaishorogukulu, and the patient will, next time when the patient visits, the patient may say that along with the other, now the patient has a better feeling with the legs. Earlier the patient would not be complaining anything about the pain in the legs as such. So this kind of a presentation is also common with the varicosities. Then usually the pain would be a dull aching type of the pain, which is related to the long standing. When the patient stands for a long duration, there could be a dull aching pain, which is a characteristic feature of the varicosities. And usually the symptoms will improve on walking or elevating the legs, keeping the legs elevated or walking. The condition improves. Now this helps you to differentiate between arterial pathology, ischemic conditions, or the venous conditions. Venous conditions will be feeling better when the patient walks, whereas arterial conditions, the condition will worse on movement and elevation. Then often in pregnancy or in during menstrual cycle, the symptoms may aggravate in case of varicosities. And again, some of the particularly female patients, may complain of this pain after sexual intercourse. That's due to the pelvic congestion during that condition. So that's about the typical clinical presentation, which helps you to differentiate between the other overlapping symptoms and primary issues of the varicosities. The complications which can occur due to the varicosities could be varicose eczema or skin changes, ulcers, variceal bleeding. So many of the varicosities they may rupture by themselves, and there could be profuse bleeding. And the bleeding which occurs due to the varicosities can be easily stopped by a compression bandage. So a simple compression bandage would be enough, though some of the patients may panic because of the quantity of blood and a passive continuous flow of blood. A varicosities also can result in thromboembolism. A clot may occur, and the clot may migrate, and a migrating clot can produce the complications like either a pulmonary embolism or anything embolism, any of the other organs like cerebral or cardiac or renal, so on. A floating clot can get obstructed somewhere, and thromboembolism is something which we will be discussing separately in due course of time. Then the very prolonged one can produce the equinus deformity, contractures of the tendons, and hence the patient's leg may remain contracted as such. Among the management of varicosities, the most important aspect of the management is the lifestyle, and the exercises are the best of the options. There are many sorts of the exercises which are suggested. You find a lot of such issues which are often confusing. In the internet you see like lot of these kinds of exercises are suggested, but I think most of these are not really necessary. A simple exercise which we call as a Bisgard's exercise would be quite good enough. The Bisgard's exercise is ask the patient to walk with the tip of the toes touching the floor when he walks. So the gait has to be modified in such a way that the patient walks with the tip of the toes first, then the heels first as such. So that makes the calf muscles contract more, and the contraction occurs, the drainage in the deep veins would be improved, and that makes the patient more comfortable with the varicosities. So skin circulation will improve. Then the bandages, compression bandages are the other standard protocols of the treatment. Compression bandages are of different types. It could be simple elastic crepe bandage, or now lots of ready-made types of that stockings are available. With all these, there are two important issues which you have to consider. One is, if at all you are tying the bandage, it should be always from the distal side to the proximal side, so that the blood flow in the vessels are squeezed out. If at all the bandage is tied the other way, like from the proximal to the distal side, then there could be more congestion that can worsen the condition, and most of the times this primary issue, simple issue, might be neglected by the patient. Another problem would be the maintenance of the hygiene. With these types of the elastic bandages, if they are not kept hygienically clean, or if some dust particle goes in, that can trigger the ulcer formation, injure the skin tissue, and then that can result in the complications. And hence, I generally do not advise a bandage to the patients of varicosities. Then the other options which are the standard protocols in the contemporary situation is I ablate the varicosities. Now remove the varicosities or intervene with the varicosities. One of the important precautions is any such interventional therapy of the varicosities should never be done if the deep veins are not patent. So before we go for any sort of the intervention therapy, you have to be very sure that the deep veins are patent. If the deep veins are not patent, if the deep veins are obstructed partially or even completely, intervention with the varicosities is absolutely contraindicated. Now, in such conditions where the surgical intervention is done, the only benefit would be you will be removing the superficial veins which are drained, but there would be no other alternative drainage system, and hence temporarily there could be a reduction of the congestion, but in long run most of the surgical interventions, they will result in more complications as such. So a prolonged advantage from the intervention procedures are not very significant. Moreover, the complications of sclerotherapy, where you inject a fibrosing agent into the varicose, which is also are quite significant, and hence that surgical treatment is not a very popular option of the treatment, but still these are tried, and the technologies also are many. There could be either sclerotherapy or lasers. With the laser, they could be ablated, or radiofrequency laser ablation, or ambulatory phlebectomy, where the veins are removed by completely, or surgical approaches in case large vein varicosities could be either ligation of the saphenofemoral wall without stripping or with the stripping, and phlebectomy, where the veins are removed with small incisions, or endovenous thermal ablation or laser thermal ablation could be the other options. From Ayurvedic point of view, I would be considering these varicose veins as the Siraja Granthi, where the typical presentation is mentioned like Vyayamajataihi avalasitaihi srihi akshipya vayuhu sirapratanam sampidya sankochya vishoshachapi granthim karoti unnatam ashurtam grantisthirajaha sakritsasadhyah bhavet yadisyad sarujaschalascha aruksayapi achalo mahamsya marmochidasyapi vardanyah. The characteristic feature would be there will be dilated vessels, and these dilated vessels would be producing a swelling which is visible, and characteristically it will be painful in the initial stages, and when it is painful it is curable, or it can be managed better because it is in the initial stages. In the later stages it becomes painless, or intensity of the pain will be lesser. This is the typical characteristic of the varicosities, and in such conditions Sushruta has considered Vivarjaniya. The options of the treatment which I would prefer in case of varicosities would be Kaisharogulu, Purnamandura, Manjasaripata, along with the lifestyle like either the exercise and the elevation. Another option which is often tried in many centers, Ayurvedic centers, is Raktamokshana, Siravyatha. But from my observation point of view, the Siravyatha Raktamokshana produces only a temporary benefit but may not be the long-lasting benefit. But it's a quite popular form of the treatment adopted by many Ayurvedic centers. When I discuss about the Ayurvedic treatment for varicosities, if I do not mention about the Siravyatha, I think that would not be a proper issue, though I may not use it quite frequently. Then the next issue is the management of the venous ulcers. Now, venous ulcers are produced as a complication of either varicosities or any of the other conditions where the microcirculation is affected. Microcirculation on the venous side, there is a congestion of the blood in the area, subcutaneous area, that is producing a discontinuity of the skin, that is a venous ulcer. And the pathology of venous ulcer is because there is a stagnation of the blood, the pressure in the capillaries would be increased, which results in leakage of the protein from the capillary circulation, and that also would be having impairment of the oxygen and growth factors supply to the peripheral tissue. The supply of the oxygen and the growth factors will be lesser, which induces a local inflammatory response, and that inflammatory response continues further step by step, resulting in a wound as such, and that wound will not have a proper healing process. And the typical clinical presentation would be, initially the person would experience itching with or without a rash. Then there could be aching pain in the gaiter area, that's in the shin area. Then the next course would be, the patient may have a pleural edema, mostly at night or evening hours, at the end of the day as the patient works. Then it results in night cramps, and then there will be the further changes like the pigmentation or ulcers could occur. There could be dermatitis, which can become blackish in color, or even lipodermatosclerosis can occur, which produces like visible deformity, which as I have shown you in the image as such earlier. So that conditions may occur as the next course. A venous ulcer is characteristically superficial and agranular. It may present in any stages, like either at times it could be fibrous, and there could be deeper involvement also, superficial also, but it's a deeper involvement, but a flat surface, characteristically agranular. Edges would be very flat, thin edges are the characteristic feature. Either with the necrosis or without necrosis, they may present in any form as such. The lower limb ulcers presenting in the lower limb, they could occur due to the other causes also. Venous ulcers or arterial ulcers or neuropathic like diabetic ulcers or pressure sores also can occur, and they have to be differentiated. The differentiation would be by either the underlying condition. In the venous ulcer, there would be some underlying condition like varicosities, or maybe history of thrombosis or obesity, pregnancy, etc. Whereas in the arterial ulcer, you will have the complications like diabetes or hypertension, smoking, etc. Neuropathic ulcer often produced with either diabetes or nerve injury. Pressure ulcer, where there would be reduced mobility or some trophic factors. Location of the ulcer in case of the varicosities is usually in the lower calf of the muscle towards the medial malleolus at the shin or gaiter area. The ischemic ulcers usually are at the terminal part or at those areas where there could be relatively thinner tissue over the surface of the bone, and characteristically it will be present with a punched out edge and deep ulcers, whereas venous ulcers are superficial and flat ulcers, flat margins, and shallow, very superficial ulcers they will be seen, and there will be serous discharge in case of varicose ulcers, whereas the arterial ulcers may present with the necrotic changes, gross necrotic changes. Neuropathic ulcers, they are usually produced over the callus area, we present with significant callus hardening around the area, and the surface would edge would be punched out, typically punched out. Pressure source, that at that point where there could be pressure as such in a lying bacterial patient, it may occur. Then if you look at the surrounding area, in a varicose ulcer or venous ulcer, there would be signs of stagnation, that blackish pigmentation around the area would occur, whereas in case of the ischemic ulcer, in the surrounding area there could be pallor. In patients of pressure ulcer, neuropathic ulcers, there could be hyperkeratosis. Pressure source again can be necrotic changes around the area, and that's how it has to be differentiated. Now, the varicose ulcers or venous ulcers are graded based upon clinical, etiological or pathophysiological components or anatomical components, either clinically based as C0 to C6, like no visible palpable signs of venous disease, to active venous ulcer at different stages depending upon the clinical presentation. Etiologically, congenital, primary, secondary, or no venous cause is identified, without identified causes. You may name it as EC to EN, or anatomically where there is a superficial vein or perforated vein or deep vein, depending upon that you may say use the nomenclature like AS to AN. And pathophysiological, if there is a reflux or if there is an obstruction or there is obstruction as well as reflux together, or no venous pathophysiological identifiable. So these would be the grading of ulcers by which you can predict about the intensity. This is a standard protocol of reading the venous ulcers, which are not regularly followed, but in research articles to follow up the patient, this could be the one of the issues. As far as treatment options are concerned, the standard protocol of the treatment is compression, intermittent pneumatic compression, like where there would be a specific instrument which can put the pressure intermittently. Then manual lymphatic drainage also, where you can do the massage. That's also the other form of the treatment. Extracorporeal shockwave therapy is the usual protocol of the treatment. In case of varicose ulcers or venous ulcers, administration of the antibiotic is generally not needed, and local application of any irritant substances, very active substances also are not suggested. It should be mild, non-irritant substance which has to be placed in. Whereas comparatively, compared to all the other contemporary protocols, our treatment protocol of Tribala-Quadriprisheka, Gatya-Kela, Kaishara-Guru, Dandakarasana, Manjishta-Alikwata are much better than others. Then as far as Raktamokshan is concerned, of course, Raktamokshan may reduce the congestion temporarily. In the long run, the advantage is questionable, but still it's one of the protocols which are followed many times, and often some of the patients may show some gratifying results. That's about the varicose veins and its complication of varicose ulcer. The next part which we discuss will be deep vein thrombosis. Deep vein thrombosis is due to certain commitments. We'll continue in the next session. Deep vein thrombosis. I will stop early, so we'll stop today. If there are any questions, we'll try to answer and then continue in the next session about deep vein.